Good afternoon. Welcome to today's webinar entitled Mom's the Word, Signs, Symptoms, and Treatment of Perinatal Mood Disorders. I'm Irina Polanco-Ventura, Director of Public Health Initiatives at the Partnership for Maternal and Child Health. We have reached the final talk of our perinatal mental health webinar series, and I'd like to express my sincere gratitude to all of the speakers who participated and provided our listeners with excellent and informative presentations. We would also like to thank the New Jersey Department of Health for funding these webinars and allowing us to bring them to you. During this presentation, we will be muting all attendees, but please feel free to use the chat box for questions, and the speaker will respond to as many as possible at the end of her talk. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. An hour after the webinar ends, you will receive a link to a post-program evaluation. Please complete the survey to provide us with feedback on the program. Certificates will then be sent via email within 1 week of the webinar. Now on to our speaker. Dr. Carly Snyder is a reproductive and perinatal psychiatrist who blends traditional psychiatry with a holistic touch. Dr. Snyder received her medical degree from NYU School of Medicine and completed her general psychiatry residency at Mount Sinai Beth Israel Medical Center with additional reproductive psychiatry elective training at the Payne Whitney Women's Program at New York Presbyterian Weill Cornell Medical Center. She maintains a private practice on the Upper East Side in New York City, where she serves as Director of Women's Health for Family Health Associates. Dr. Snyder is voluntary faculty at New York Presbyterian Weill Cornell and at Mount Sinai Beth Israel Medical Centers. She is on the Advisory Council for Postpartum Support International and is a board member for Help Us Adopt. Dr. Snyder is also a member of the Independent Doctors of New York, Robin Network, and the Women's Mental Health Consortium. Thank you for being with us today, Dr. Snyder.
Thank you so much. Whenever I hear that bio, I'm like, wow, I need to relax. Anyway, I'm really excited to be speaking to everyone today about what I feel is an incredibly important topic, being signs and symptoms and identifying the woman who needs treatment for a perinatal mood disorder. So this is me. And I think before we even start, I just want to say that today alone, for example, I've already had 3 patients who I've spoken to about the risks and benefits of treatment in pregnancy. And with each woman, we go through a similar risk-benefit scenario that we're going to talk about today, but obviously every woman's history is different. And it's just important to note that these are not decisions that are ever taken lightly. These are, they're very important for the woman and for myself as the physician. In a perfect world, every pregnant woman would be happy and great and wouldn't need medication, but unfortunately that's not the case. So as with any illness in pregnancy, diabetes, high blood pressure, what have you, it's imperative that we treat so that a woman can be at her best self and feel her best during pregnancy and beyond. Okay, so I have to say I just love this little this little slide. It's anyone who's been pregnant realizes that it's not necessarily bliss. It's rarely easy, and this pregnant woman lists a whole bunch of reasons why, but it's a positive time in a woman's life. If you layer on a mood disorder though, all of these can go from being really uncomfortable to actually being intolerable, and what should be a positive time can become a nightmare. And I think as providers, our goal is to help women again feel their best and not get to that point. So just quickly want to throw this slide in here. I have no financial disclosures. Okay, so today, the outline quickly, we're going to go through facts about perinatal mood and anxiety disorders, briefly talk about how to assess a woman. We're going to talk about the risks of untreated illness, the possible risks of exposure to medication. We're going to talk in general about medication considerations, and then we're going to go through 5 case studies with treatment plans. And throughout, I think it's important just to remember, you know, a happy mom, happy and healthy future baby. Okay, so another fun one. I think this encapsulates what most women think of when they think about taking medication in pregnancies. They fear, oh my God, what if I have a 3-headed baby? As providers, our job is to understand the risks and mitigate fears by providing up-to-date information to really help women make informed decisions. I don't make a choice for any patient. I give her all the information and allow her to make that choice, which is best for her. Though it's important also to remember perinatal mental illness is potentially deadly if it's severe and untreated. Suicide is one of the leading causes of death during the first year postpartum. And the good thing to know is that treatment is incredibly effective, incredibly effective. So, you know, when we talk about PNAS, perinatal mood and anxiety disorders, I think most people, you know, today we're going to be talking mostly about pregnancy, but most people still kind of clump everything into depression. They say postpartum depression, or I had postpartum, or what have you. It's important to remember that there is a whole spectrum of illness. The only 2 of these which cannot be seen in pregnancy would be a postpartum psychosis, by definition is postpartum, and the baby blues, which is not specifically a mental health disorder. It is a response to hormone shifts, but you know, 70 to 90% of women experience it. Symptoms self-resolve within 2 weeks. And if symptoms don't resolve, that's when we can, you know, consider interventions for possible postpartum depressive episodes. But just important to remember that depression, anxiety, panic, OCD, and PTSD are all possible disorders that can occur during pregnancy, as can, you know, bipolar disorder, but specifically postpartum psychosis cannot. This is basically, so really you can start developing a mood disorder anywhere in your pregnancy through 1 year postpartum. The American Psychiatric Association's definition of postpartum depression says that it has to have an onset either during pregnancy or within the first 4 weeks postpartum. And ACOG, the American College of Obstetrics and Gynecology, they say you could have a major or minor depressive episode in pregnancy or the first year through the first year postpartum. I like to think that the best definition really is a combination, because there's no such thing as minor depression. So in terms of ACOG, that doesn't work. But the APA should take on the stance of symptoms being, presentation being up to 1 year. The current guidelines are truly inaccurate. They don't make sense, because a lot of women will present, sure, some present early, you know, postpartum, but also they will present during pregnancy, as I said, but anywhere from 3 months, 6 months, anywhere postpartum in that first year. So who is at risk? You know, a woman with a high genetic load obviously is at risk. This is a woman whose mother or maternal grandmother may have suffered from a perinatal mood and anxiety disorder. I always ask patients whether they know if their mom suffered at all. Oftentimes the answer is no, but it's still something to be aware of. I also obviously get a full family psych history, which can also be very helpful. Any woman who has a pre-pregnancy history of a psychiatric disorder also faces an increased risk, especially if she's off her medications. So, and of note, if a woman had a prior episode of postpartum depression in her last pregnancy, she's got about a 50% risk of a recurrent episode. If she had postpartum psychosis, that risk goes up to 80 to 90% for a recurrent episode. Another big factor would be the psychosocial factors. So lack of support and social isolation, poor sleep, poor nutrition and financial stress. Times of hormone shifts are actually very important during pregnancy. Obviously, our hormones are increasing exponentially, and then at delivery, they go down like a ton of bricks, which is where we get the baby blues. There are definitely some women who have a clearly hormonally driven postpartum depressive episode where they're okay in pregnancy, but then they start to feel quite sick shortly after delivery, and it persists. The other thing of note would be there are some women who struggle with mood symptoms around the time of weaning from breastfeeding. I think that that is also because of social factors, and you have to take into account, does she want to stop breastfeeding? How old's her baby? There's so many things, but it is something just to be aware of when you're talking to someone and to ask whether or not she recently weaned. So breastfeeding unto itself, frankly, could be its own talk, because it is something which a fair number of my patients have anticipatory anxiety about during pregnancy. And then if it doesn't work as planned, it can be a huge, huge source of anxiety, of depression. Women often feel like failures, even though they're not. And it's very important that while we support breastfeeding completely for any woman who wants to, that we also appreciate that it is not possible for some women, and that's okay, and to give those women the freedom to stop. Other risk factors, so reality of pregnancy and motherhood are not equal to fantasy. That just being, there are no butterflies floating around our head in pregnancy, and the postpartum period is not always easy, and for some women that difference is very hard between what they thought it would be and what it is. If a baby is in the NICU, that obviously will increase the risk. There's a lot of anticipatory anxiety before going back to work, partner strife, and age. Younger women are at an increased risk. This is not by any stretch an exhaustive list, however. So years ago, the thought was that being pregnant protected you from a mood disorder, and this is just not the case. You can look at the numbers here that, being depressed or anxious in pregnancy, it's not rare. And in fact, my guess is that the numbers are actually quite higher than what we see here, but because of ongoing social stigma, unfortunately, too many women remain silent about their symptoms. So a good friend of mine, Liz Cox, did this, what I think is a really elegant study, and she was looking at how many patients are identified and appropriately treated for mood disorders in pregnancy and postpartum. And her results are just shocking and say very much that we need to do better. So if you just look through this, during pregnancy, maybe 50% of women are identified as having depression, 30% postpartum are identified. Then from those numbers, it just goes down so exponentially, right? So 13.6% of women who are pregnant receive treatment, but only 8.6 are actually getting adequate treatment. Whereas postpartum, we have, 15.8 and 6.3, again, so low. And then the saddest numbers here, that only 4.8% of women achieve remission in pregnancy and only 3.2 achieve remission postpartum. And it's just incredibly important to note, especially in the postpartum section, that having mom be sick impacts not just her, but in pregnancy, it's impacting her fetus, and postpartum, it impacts every single member of the family. So why are women not getting treatment appropriately? Well, as I said before, stigma is definitely involved. It keeps women from identifying themselves as and asking for help. There's shame, there's guilt, there's a lack of understanding what's going on. Especially postpartum, there's this misconception that it's supposed to be really tough, it's supposed to be awful, and that's just not true. Unfortunately, there is also a lot of fear and a lot of antiquated information floating around amongst prescribers, such that women too often get really poor advice and are not appropriately treated. We also, as I said before, there are no clear professional guidelines on identifying or treating pregnant women. And there is, even if a woman looks for a provider, sadly, we are few and far between. So it's incredibly important that more people understand treatment and can help. So we're going to quickly run through the assessment steps. So when I see a patient, obviously I take a thorough history. If a woman wants her partner or spouse to be there, that's great. If she doesn't, that is her choice. You can use the screening tool if you want, the Edinburgh, we'll talk about in a moment. It's a good idea to check labs or, send someone to their internist to do so. Rule out any organic causes like thyroid abnormalities. You also want to ask about and document all exposures, especially marijuana. This is a huge one right now. Women think that because it's natural, it makes it safe. So I've had many patients who, say, well, I'm not smoking it anymore, but now I'm using edibles and that should be fine, right? And the answer is no, absolutely no. We have more and more data suggesting and supporting the idea that exposure to cannabis in utero has detrimental effects and also postpartum. Also, it's great to contact collateral, not just the referring person, but also, if not one and the same, the OBGYN. You really want to be on board together. This should be a team approach so that a woman gets the same message across the board. So these are optional screening tools. The most commonly used one is the Edinburgh Postnatal Depression Scale. A score of 10 to 12 is kind of a gray area. Talk to the woman and see. But 12 or above absolutely should be referred for evaluation and treatment. And then the question is, well, why? Why am I saying that we should treat in pregnancy? Well, because there are legitimate risks to untreated illness. So we are going to see here, the ones in italic here, you can see, are also associated with exposure to medication, to SSRIs. However, it is much more common to have much smaller babies and babies who are born much earlier in the setting of untreated illness as compared to in the setting of exposure to SSRIs. You can just read through here the list, but we're really talking about a baby who is struggling in a lot of ways. Low APGAR, so at delivery, APGAR and Brazelton scores, they're not as attentive though. They don't make facial expressions as often. They're irritable. They're not as active, and they don't sleep as well. Also, developmentally, you can see delays at 18 weeks, and this continues through to toddler years. You can read here how there's lower cognitive language development. Also, there's an increased risk of ADD and MDD, major depressive disorder, and ADHD in school age and adolescence. Of course, we can't rule out the fact that genetics also play a role in this, but I do want to note that all of these results, all of these are independent of the risk posed by exposure to a mom who is suffering from postpartum illness. And the biggest risk for postpartum illness is antepartum illness, meaning if you're depressed or anxious in pregnancy, you're going to deliver, and more likely than not, it's just going to get worse, not better, because of the lack of sleep and so forth. That can have negative impact, obviously, for mom, but also for her baby. But these studies that I'm showing you now are solely looking at exposure during pregnancy. This one is very impactful to me as the mother of 3. We all know if we have kids that baby sleep is, it's paramount for everyone. Well, a baby who has been exposed to untreated illness is less likely to sleep as well. They have a longer time to fall asleep, to stay. They don't sleep stay asleep as well, and the total number of hours they get of sleep in a 24-hour day is less than babies who were not exposed to untreated illness. Okay, so what about for mom? Well, mom's less likely to obtain prenatal care. She won't, if you just think about a woman who is depressed and anxious, many have poor appetite, many don't sleep as well. Often motivation and energy are low, so exercise goes by the wayside. Many women will forget their prenatal vitamin, and they don't connect and bond with their pregnancy as they otherwise would. However, they are more likely to self-medicate with drugs and alcohol, take excess over-the-counter medicines. Of note, there's been studies that show that taking Tylenol for at least half your pregnancy on a daily basis has been associated with a hyperkinetic ADD. So it's hyperkinetic syndrome, which is like a very severe ADHD. They're also more likely to develop gestational diabetes, preeclampsia, to deliver early, require C-sections, and have forceps deliveries. The gestational diabetes and preeclampsia, there's also hypertension that I didn't write. Part of that is also about how mom is taking care of herself. If she's not, she also, if a woman has gestational diabetes, she needs to be monitored very closely by her OB. But as I showed over here, women are less likely to obtain prenatal care. So what happens? Well, untreated or minimally treated gestational diabetes can become, can actually be life-threatening to a fetus. So it's important that women get treated because obviously of the implications directly, but also the secondary implications of not going to one's OB appointments and taking good care of yourself. This is an interesting thing, pregnancy-specific anxiety. I will say I have so many of my patients experience this. It is not an official diagnosis, but this is women who are pregnant and they're very, very anxious about the health of their baby. What's labor going to be like? How am I going to deliver? What's being a mom going to look like for me? And, anyone who's pregnant will say, well, I'm worried about that too. Don't we all? Yes. But women who have pregnancy-specific anxiety, this becomes their life. They are in many ways can't get past these fears and can't think about the positive. Instead, they are stuck with these fears. There is strong evidence linking pregnancy-specific anxiety to negative impacts in offspring, including preterm delivery and neurodevelopmental effects. You can read through them, but these are just a small spattering of the risks. It's a significant issue. Okay, great. So I've given you all these reasons that we should treat, but what about the risk of exposure to medication? This is a big source of concern for a lot of people. But in fact, a lot of the fears that people have are not founded. For example, for a long time, people said that that medications increase the risk of miscarriage. But in fact, a study showed women who had untreated illness and women who had stopped their medication early prior to pregnancy or just right at the start of pregnancy versus those who remained on medication in pregnancy, both had an increased risk of miscarriage as compared to the group who had no symptoms whatsoever. So, compared to the control group. So basically we're saying that this is from the underlying illness, not from the treatment. So people worry a lot about birth defects. There is no consistent defect associated with the use of SSRIs. 3 to 5% of all pregnancies will have a major malformation. This is a population risk. None of our medications that we use to treat in pregnancy for depression and anxiety increase that risk above 3 to 5%. Again, I said earlier, small for gestational age and preterm delivery are both associated with use of medication, but also with underlying illness. So can we parse out one from the other? Not always. Now, poor neonatal adaptation syndrome is absolutely something that can happen. It is a definite risk, up to 30% of babies will experience it. However, it's really important to note, and we're going to talk about it in a second, it self-resolves. There are no long-term negative sequelae. And the most important thing about it is letting your patients know, letting these women know so that when they deliver, if their baby has any signs or symptoms of PNAS, or they're told that that may happen, that they're not freaked out, because it could really scare someone otherwise. Persistent pulmonary hypertension in the newborn. This is a very low absolute risk. You can look at the numbers here. And I just want to take 1 second here and explain odds ratios, because I put it here, but for anyone who's not comfortable with odds ratio and statistics. So the odds ratio is a measure of association between exposure and an outcome. So the odds ratio represents the odds that an outcome will occur given a particular exposure compared to the odds of the outcome occurring in the absence of an exposure. Odds ratios are often seen with case control studies, but also cohort designs as well. Really important to remember, an odds ratio can be statistically significant, but not necessarily clinically relevant. So you always also want to look at the absolute risk, which is much more telling. Also, so last but not least, neurobehavioral and neurocognitive effects. There's no consistent evidence of any long-term neurobehavioral or neurocognitive effects at all. Okay, so what poor neonatal adaptation syndrome, here are the possible symptoms that a baby may experience. Really important to realize it's transient, it's self-limited. These babies are not requiring NICU care. They're not requiring much beyond perhaps some blow-by oxygen. There's no sequelae. And as I said before, it self-resolves. But in truth, because of the 15 to 30% association between SSRI exposure and development of PNAS, it is something that OBs and pediatricians in the hospital are looking out for when a woman comes in and says she's on an SSRI. So if your patient should know that they may hear about it after the baby's born, but there's nothing to be concerned about. Just throwing in also, it's dose independent. So you want to use the lowest effective dose, not the lowest dose. And this is so key. There is absolutely no benefit from a 2-week washout period before delivery. So please don't stop medication before a woman delivers. You're basically shooting yourself in the foot, because if a woman needs treatment in pregnancy, then she needs it postpartum. And stopping medication 2 weeks early doesn't actually change any risk, and in fact increases the risk substantially that she will have a postpartum depressive or anxiety episode. Now, how about medication considerations? The biggest thing I want everyone to take away from is keep it simple. If a woman can be on monotherapy, that's great. That's the best. Is that always possible? No, but that's our goal. So you want to really make sure that whatever treatment a woman is on, that she's dosed appropriately to the lowest effective dose. And don't change what's working. There's no SSRI or SNRI for that matter that a woman could be on coming into my office that I will change because she's planning a pregnancy or is already pregnant. The only medication that is absolutely should not be used in women of reproductive age ever is valproic acid, being Depakote. That is the only medicine which, hands down, it's a mood stabilizer used for bipolar disorder, but it is absolutely should not be used in pregnancy. And given that 50% of pregnancies are unplanned, it is a risk that I, for one, would never take to put a woman of reproductive age on the medication. And there are actually some European countries that have outlawed its use in women of reproductive age. As I said before, you really want to ask and document all exposures, including cannabis, alcohol. Some women feel more comfortable or less with you drinking during pregnancy, you just want to ask in a non-judgmental way and document everything. And please encourage psychotherapy. There's never a patient who won't benefit in some way from therapy. So I kind of said this already, but when you're choosing a medicine, there's nothing that's contraindicated in pregnancy in terms of antidepressant class. You want to dose, I'm hammering this in, lowest effective dose. And important to remember that as pregnancy continues, a woman's blood volume will double by roughly week 25 or so. Her metabolism, her GFR changes, and the CYP450 enzymes that metabolize medications also change. What all of this means is that it's not uncommon for a woman to require increased dosing as pregnancy continues. That's not indicative necessarily of a worsened illness as much as it is indicative of a decreased, that basically the medication is not as effective. You have a lower effective dose at that point. What about in terms of women who want to breastfeed? There's no need to change medications at delivery at all. Exposure through the placenta is greater than that through breast milk. You can see here, there's no absolute contraindication for any of the antidepressants. You really want to use, we look at something called the relative infant dose being, as long as the medication, the RID is less than 10% of maternal dose, and it's fine. All of the SSRIs and SNRIs are within that 10%. There's some question if Prozac goes up a little bit at times, but again, it's fine. There have not been any indications of any risk associated with any of the SSRIs. As I said before, please don't shame any mom who can't or doesn't want to breastfeed. We encourage, we don't push. So I'm going to slow down a little bit because I want to talk about our case studies in detail. So we have 5 of them: Serenity, Constance, Ophelia, Deirdre, and Nelly. We're going to talk about Serenity first and go through her treatment plan, and then I'm going to introduce you to our next 4 women. And after meeting all 4 of them, then we'll talk about treatment plan. So Serenity, meaning calm, she's 32. She's been married for a few years. She's employed. She has this remote history of a mild to moderate depression in college. She was put on fluoxetine. She started therapy, and basically she's never stopped the fluoxetine. Now, does she have any symptoms? No, she's perfectly fine. Do we have any sense that she may develop symptoms? We don't know. So the best approach prior to conception is to titrate off the fluoxetine slowly and monitor for symptoms. I ask my patients during this process, just every night or every 2 or 3 nights, to rate their mood for the day from a 0 to 10, 10 being the greatest day of their lives, 0 being the worst, so that we can really have an objective scale and see where their mood is going over the course of several weeks to months. If mood remains stable, great. If mood takes a dip, well, that means maybe she does need the fluoxetine, but the only way we're going to know is if we titrate her off of it. And therapy and lifestyle changes are incredibly important. Lifestyle changes being like exercise, yoga, meditation, practicing good sleep hygiene. If there's one thing that is going to derail anyone's mood, it's lack of sleep. So it's incredibly important that we push our patients to sleep as much as possible and sleep appropriately. Eat well. The number of women who will present to me and say that they have panic-like symptoms around 3 or 4 p.m. every day. And I ask them, what time do you eat lunch? And they say, well, I eat a small lunch around 12, 12:30. Well, what happens when you have these panic symptoms? Well, if I eat something, I feel a little better, right? Because it's not panic symptoms, they're just getting hypoglycemic. So one thing to always check in on is diet and nutrition. We also want women going into their pregnancy as healthy as possible, so eating well from the get-go is important. Psychotherapy absolutely first line for mild to moderate depression. CBT, all of these forms have empiric evidence showing the benefit. Light therapy can be helpful. There's no exposure from it, that's a plus. It is best when used 20 to 60 minutes, either once or twice a day, and you just have to monitor to see if a woman becomes activated, which can happen, especially in the case of an undiagnosed bipolar disorder. And the other thing to note, this is light therapy obviously is incredibly helpful for people who have seasonal affective disorder. Acupuncture also has some empiric evidence showing its benefit. Again, this is for mild illness, though it doesn't hurt as an adjunct in any form of illness. I tend to suggest, although I don't literally push patients, to consider some supplements that are good for themselves and for their babies. Prenatal vitamin is a must. Ideally, it has folate, not folic acid. So it's okay to have folinic acid or 5-MTHF, but not pure folic acid, if at all possible. You know, is it awful if they have folic acid? No, but the natural form that our body can easily break down, even in the setting of an undiagnosed MTHFR mutation, is better. And that's going into the weeds more so than we have time for today. Also, it's important to make sure there's enough iodine in the prenatal vitamin for thyroid purposes. Magnesium is great. It is relaxing. It's like taking an Epsom salt bath. That's why people like it, is it increases their magnesium levels. In the third trimester, though, there has been association with floppy baby syndrome. Transient, not long-term in terms of risk, but it's there. Omega-3 fatty acids, frankly, I mean, it's good for us to take anyway. There is definitely some mixed results in terms of whether or not this omega-3s have any actual mood benefits in terms of treatment of any illness. I don't think that can really be said, but omega-3 fatty acids are incredibly good and important for overall health, cardiovascular health, etc. N-acetylcysteine is an amazing, amazing supplement. It's an antioxidant. What it does is it increases glutathione production, and glutathione is a super antioxidant. It has basically countless benefits for the body, but when it comes to pregnancy and pre-pregnancy and postpartum, it's a great way to reduce a woman's anxiety load. It takes like 3 weeks to work, but it can be really, really, really helpful. There's some data, it may be protective against miscarriage, definitely won't hurt. And there's actually new data that from a small flu study, influenza study from last year, showing that it may help people recover faster from the flu. And some people have postulated whether or not that could be translated over to COVID-19, to coronavirus. But of course, we don't yet have any data to support that. Vitamin D, very important. You know, one of my patients calls her vitamin D her sunshine in a jar, which literally it is. If you look at women's vitamin D levels pre-pregnancy, it's very common to see low numbers. The range of normal is quite wide, roughly 30 to 100. But it's not uncommon for me to see a patient who has a vitamin D of 20. And that can absolutely have negative impacts on one's mood and energy. And there are studies that show that if a woman has a low vitamin D and supplements with vitamin D in her pregnancy, then the likelihood of having a postpartum or an antepartum depressive episode is decreased compared to women who just had a low vitamin D that remained low. And as pregnancy continues, vitamin D does continue to go down. So it's an important thing to supplement early if possible. So now let's talk about our more ill patients. We have Constance. She's 35. She's been married for a while. She has a real history of recurrent moderate to severe illness. First presented shortly before college. She had a brief psych admission for suicidality. She was stabilized on escitalopram and therapy, and she remained on the medication until she tried stopping it in junior year. Within 2 months, she decompensated such that she had to leave college transiently. So we can kind of comfortably say escitalopram works for her. She's been in therapy since college. She has her, very nice relationship with her therapist. Right now, her symptoms while on medication, minimal. She may have a little bit of a worsened mood just before her period, but overall is okay. But again, she decompensates at lower doses of escitalopram. And her hope is to conceive in the next few months. So she started titrating off the medication in advance of this conception on advice of a former psychiatrist. But not surprisingly, she became really, really anxious. She had to take some time off from work. She's gone back to 15 milligrams and she's feeling back to herself. She's very scared, honestly. At this point, understandably, she's worried about stopping the medicine because clearly it's really beneficial. On the other hand, she's also grappling with what she's seen on Google and what, friends and family have said to her being, oh no, you need to stop your medicine. So she's going back and forth. And as I said, she wants to conceive soon. Now we have Ophelia, who, if we think about tragic Hamlet, not good, right? So we're talking about a tragic figure here. She's 38. She's relatively newly married. She's a really high stress job. She is 16 weeks pregnant. She went through extensive fertility treatment, which can frequently increase a woman's, obviously her stress, but also anxiety. And some women experience depressive episodes even for the first time in that setting. But she actually has severe anxiety since childhood. She's been on every SSRI, but paroxetine works for her. She stopped it last year and has been able to manage her anxiety symptoms somewhat using some complementary methods. But, if we look at her first trimester, she was okay. By her second, now she's really having worsening of her anxiety. She's having sleep impairment. She's not eating. She's irritable, right? She's not a happy camper. She's also drank a glass of wine 3 times already, and she then feels guilty. She usually used to exercise all the time. She has no energy to do so. She's really worried about starting medication again, but her spouse and her therapist feel it's really necessary because she's spiraling, and that's when she comes to see you. And then we have DEIRDRA. So DEIRDRA is really newly married. She is also pregnant without planning it, but she's happy about it. She is comfortably in her second trimester. She had an increased glucose tolerance test, which had to be repeated. And overall, she's feeling less excited than she had wanted to. She always wanted to be a mother, and now she's just not looking forward to things, and she's not so thrilled, which really is unto itself upsetting to her. She had a possible panic attack at her 17-week anatomy scan, and her OB first sent her to therapy, which she did for 2 months, and she likes the therapist, but it's not doing a whole lot. If you look at her symptoms, they are significant, right? They are very consistent and classic with depression and anxiety. And all of these things we talked about earlier. She missed 2 OB visits. Her glucose tolerance test is a high. She's not exercising. She's not sleeping well. She's not eating well. And her weight gain has gone down relative to what it should be. She's sad. She feels guilty. She's just having a very hard time. And, she has this passive suicidality. She, again, has no history, and her baby is a reason that she wants to live, but it's there, and that can be very discomforting for people. Last but not least, we have Nelly, who is pregnant with her second child. She is having these intrusive thoughts, which you can see on the right there. She has had them for about 5 weeks. She feels guilty. She can't sleep. She also is not taking care of her toddler because she's worried about these intrusive thoughts. First pregnancy, she had something like this, but not so bad. Saw a therapist, kind of helped. She had symptoms on and off since then, but they were manageable until now. And these are a list of, common intrusive thoughts. I know you had a lecture on this topic last week, I believe, so we don't have to belabor it. But the big thing to note is that the baby is prominently featured often. But so important, perinatal OCD, women, these are ego dystonic thoughts. These thoughts really freak them out. They feel awful. They are incredibly reality-based, and their risk of violence is low to non-existent. Whereas in the setting of postpartum psychosis, where you will have what's called egosyntonic delusional thoughts, baby's a demon, baby's possessed, or I have to protect baby because of, this terrible risk that no one knows but me. May have auditory hallucinations, paranoia, doesn't sleep. Her risk for infanticide is actually 4%. Her risk for suicide is 5%. So postpartum psychosis is absolutely a medical and psychiatric emergency. These women need to go to the hospital, but perinatal OCD is not. So I just sort of wrote here again what we just talked about. So what are we going to do to treat them? Well, everyone is going to benefit from therapy, right? We're just going to encourage those who are already in it to stay, and those who are not, we will set them up with therapy because it's just so incredibly important. Constance, if you remember, she had this history of severe depression, and it recurred when she lowered the escitalopram in the past. Now she's looking towards pregnancy. The answer is to keep her on the escitalopram, speak to her about the risks and benefits like we talked about throughout this past hour, and help her understand how beneficial her mood is in terms of that being stable mood-wise is more important ultimately than anything else. The risk from the escitalopram is nil relative to the risk that would present if she stopped it and became sick. Now, Ophelia is a great example of that because she did stop the paroxetine. She's now sick. Paroxetine is the only medicine that works for her, so that is what we're going to resume. There are people who get concerned about paroxetine and cardiogenic anomalies. The answer is, first of all, for Ophelia, she's already in her second trimester, so that is no longer a concern. But even if we were talking about someone who was not yet pregnant or was newly pregnant, the risk is actually quite low. And some studies suggest it's actually not even higher than the risk for seen by any other medication. Often women will get referred for a second trimester echo in the setting of being on paroxetine, which actually can lead to something called ascertainment bias, because they find little holes and what have you in the heart that would actually spontaneously close if no one had looked, but now we looked, so we know. DEIRDRA, we're going to start sertraline. She's a pregnant patient who has no psychiatric history, but is really suffering now. Sertraline works beautifully in pregnancy in general. It's very good for anxiety, it's very good for depression, and most women tolerate it well. We also have the most data overall on using sertraline. Now, NELLY needs either sertraline or fluoxetine. Either way, because fluoxetine happens to be very good in the setting of OCD, but you could try sertraline as well. Overall, people who have OCD often need higher doses than others, but again, titrate and adjust it to the point at which she feels okay. So this is just basically saying the same thing. First line treatment for moderate to severe illness is pharmacotherapy, meaning medication, and then therapy and lifestyle modifications. Other options, ECT is absolutely an option in pregnancy if necessary. It's probably underutilized. Women do need to be monitored during ECT by OB, and there are changes. The parameters for the medications used are changed because of hormone changes, but it's very effective. I want to just throw in a quick slide on Zulresso, which is brexanolone, which is the IV infusion for moderate to severe postpartum depression. No woman in pregnancy yet has been infused, but this is for women who have onset of symptoms in the last trimester through the first 6 months postpartum. Brexanolone is identical to allopregnanolone, which is we naturally produce, and findings from the trials showed really rapid, profound benefit with reduction, 62.3% reduction in HAM-D scores. In practice, it works really well. Are there issues with it? Yeah, it's very expensive. However, that issue is mitigated by the fact that Sage Therapeutics will cover the cost overall. They work very closely with insurance companies, and women I don't think I've heard of any woman who's had to pay out of pocket for the cost, which is 30 some odd thousand. The biggest issue is finding a REMS approved facility close by that is infusing. This is obviously even a bigger issue now with COVID-19, but it is still, it's sometimes hard depending on where you live. I know you guys also had to talk about this. Dads can experience postpartum depression anxiety too, and dad will benefit from treatment. It's really important to ask how he's doing, because very rarely will men voluntarily disclose, but they should. They need treatment, and it works. So the big take-home message here, again, healthy, happy mom, healthy, happy baby. Treatment works, and treatment in pregnancy and postpartum really benefits mom, her future baby, and the entire family system. And this is me, my information. And I would love to take any questions.
Thank you, Dr. Snyder, for that wonderful presentation. Now we will take a few minutes to answer some of the questions from the participants. So I have here very positive feedback from Cynthia. This has been one of the best presentations I have heard. Thank you so much. What can be the diagnosis? So nice. What can be the diagnosis after 1 year postpartum if we can't use postpartum depression?
So first, it's important to know postpartum depression is in the DSM. It's actually a modifier, so it's depression with postpartum onset. It used to not even be in the DSM at all, which is ridiculous. After a year, you just use, if a woman has major depressive disorder, that's her diagnosis. If she has generalized anxiety disorder, that's her diagnosis. Nothing fundamentally changes at a year, except that, we can no longer say it's primarily secondary to being pregnant and being postpartum. So after a year, one should go to the more classic diagnoses. Frankly, I'm a big believer that the diagnosis is only important as it relates to figuring out how best to treat a woman. Beyond that, it's all semantic.
Well, thank you. We actually get that question a lot. Here's another question from Naomi. You mentioned marijuana use while pregnant. I work with substance-induced newborns. Can you elaborate on the effect it has on the newborn and research available so I can read into it more?
So if you somehow get your email over to me, or you can email me, I think my email's right there. I'd be happy to send you several studies. In terms of withdrawal, I don't know that they have a poor neonatal adaptation syndrome like presentation. Quick aside, PNAS is not necessarily from withdrawal in newborns. It can also be the opposite. It could be from actually having too much. It's very dependent on the baby. But when it comes to marijuana, what we know more is about the long-term negative consequence from neurocognitively. So these babies are more likely to have developmental issues and neurocognitive issues as they grow, but I can send you some more info specifically about delivery it's a great question. I'm not 100% sure.
Okay, thank you. So I think Laura needs clarification on a term used, NAC. She would like you to repeat what that stands for.
Oh, sure. N-acetylcysteine. And so it's dosed usually 600 to 900 milligrams once to twice daily. Frankly, it's beneficial for everybody. I mean, I recommend it for all of my patients because it is so effective for really intrusive anxiety, especially. The biggest thing to remember is it takes a few weeks to work. So you have to remind people that, because otherwise they get frustrated. But it is very, very effective. It also, as an antioxidant, it works to reduce free radicals in our bodies, helps repair cells, minimize cell damage. It's a really phenomenal thing. I mean, supplement. I take it because there's no reason not to, as far as I can tell. Everyone has to make whatever informed decision they want in terms of comfort, especially during pregnancy, but it is a very, very effective antioxidant option.
Okay, thank you. We have, I think, time for 2 more questions. Dina asks, can you further explain the difference between receiving treatment versus adequate treatment?
Yeah, that's a great question, because the numbers, I mean, in both scenarios, the numbers are really, frankly, piss poor, but a woman can receive treatment that is ineffective in several ways, right? So often, like we talked about before, physicians and clinicians, providers are scared of treating in pregnancy. They don't know what they're doing, or they're fearful from a medical legal standpoint. What that translates to is women being on too low a dose of medicines, not adjusting the dose as a woman's pregnancy continues. So perhaps she starts something, but then, you know, for example, if an OB starts Zoloft or sertraline at 25 milligrams, okay, she's technically getting treatment. 25 milligrams of sertraline is going to do a whole lot of nothing for the vast majority of people, especially pregnant women. So it's not just about getting a medicine, it's getting the right medicine at the right dose. And similarly, therapy has to be the right fit with the therapist for there to be benefit. You know, I think everyone's heard about not great fits, and especially during this time where women otherwise feel very vulnerable, it's important that she feels very connected to her therapist. I think especially, I will throw in, you know, with COVID-19 and everything else, women are feeling so vulnerable and are so isolated that it's important to remind them that they can do virtual therapy, because, you know, and that there are some studies that say it's just as good as in person. The therapy is important, and treating effectively, not just putting someone on a medicine without following up and titrating.
Great point. Thank you. Thank you for saying that. And here's the last question from Julie. As an OB provider, we will generally discourage the use of paroxetine in women planning to become pregnant. But in women who have been on this, and if she has a family history of congenital heart disease, what is your general recommendation to mitigate her risk of a medication factor increasing her risk?
I mean, it's a great question. The data does not support, so we had old data that suggested that paroxetine increased the risk for cardiogenic anomalies significantly, and that has been debunked. That being said, there's still a lot, people are skittish around paroxetine. If this woman that we're talking about is not yet pregnant, if she has a family history of cardiac anomalies anyway, so that's going to be high on mind. If she is willing to, theoretically, she wants to, you know, cross taper to something else that theoretically may have a lower risk, okay, but that's going to take a long time. If she is on, you know, I think there's just sort of, you have to have a really frank conversation with her that it is, we can never say anything is risk-free. We can't say anything may not cause or may not be involved in a major malformation or anything else. We can just say that based on data, the risk is not above, doesn't increase from the population risk of 3 to 5%. And there are definitely studies that are completely refuting the idea that paroxetine increases the risk for cardiogenic anomalies. But again, we have old data that suggests maybe it does. I think you kind of have to talk to your patient and really see how she feels, and also take an incredibly detailed psychiatric history. If she has tried everything and this is what works, well, this is probably what she should stay on, because otherwise, you're kind of chasing her tail, and then you end up having her on, for example, like a newer antidepressant where we really have no data. And is that, safer? I posit no.
Absolutely. Well, thank you. Thank you again, Dr. Snyder. I guess we've, reached the end of our broadcast. If you have any more questions or are in need of more information, please contact us at info@partnershipmch.org. Also, the recording for this program will be available on the Partnership's YouTube channel shortly afterwards. A calendar of our upcoming virtual programs can be found on our website under the Professional Education tab. We encourage you to share today's and other webinars listed there with your social networks. A final reminder that in about an hour, you will receive an email with a link to a post-program evaluation. Your feedback is important, so please take the time to complete it. Certificates of completion will be sent via the email you provided on the evaluation and should be received within 1 week. Thank you once again for tuning in. This year, May, which is Maternal Mental Health Awareness Month, will be remembered as unparalleled and challenging, as many families have been forced to deal with difficult realities because of the coronavirus pandemic. Right now, pregnant women, new mothers, and their families need our support more than ever. So we hope these webinars have enhanced your capability to care for those you serve. My sincere gratitude to the perinatal providers who have been on the front lines, and also to those who transitioned instantly to virtual and remote platforms to continue providing support during this crisis. So remember, this too shall pass. Thank you again for joining us. Be safe and take care.